Good morning, dear students. In this session, we are going to discuss about rheumatic heart disease. Rheumatic heart disease, it is a complication of rheumatic fever. In rheumatic fever, when it is affecting the carditis or when it is affecting the heart, the multiple valves can be involved and it can progress into rheumatic heart disease. Regarding the definition of rheumatic heart disease, it is a chronic condition resulting from rheumatic fever which involves all the layers of the heart, that is, myocardium, endocardium, and pericardium is involved, and that's why it is known as pancarditis, and it is characterized by scarring and deformity of the heart valves. The commonest valves affecting are the mitral and aortic in that order. The first one is mitral, more commonly seen, and the second valve involved is aortic valve. However, all four valves can be affected. The disease is basically valvular heart disease, as we already told. Like, it is developing rheumatic fever, and as a major criteria, carditis is the, and when the pericarditis is happening for the heart, it involves the heart valves either in isolation or in combination, and destruction of the heart valves can lead to rheumatic heart disease. According to the poor frequency of incidence in pediatric population, the commonest heart valve involvement is in the mitral valve, and it is mitral regurgitation. The second is mitral stenosis. According to the frequency of incidence, the third one is aortic regurgitation, and the last one is tricuspid regurgitation, and it is very rare comparing to mitral regurgitation and mitral stenosis. Tricuspid regurgitation is very rare among children. Regarding the etiology, as it is a complication of rheumatic fever, the first etiological factor is group A beta hemolytic streptococcus. So, definitely the group A beta streptococcus infection can lead to an antibody production which react in autoimmune defense mechanism is initiated, and it leads to rheumatic fever. And in rheumatic fever, when carditis is happening, it can lead to pancarditis and it can lead to rheumatic heart disease. The risk factors are very similar to rheumatic fever because it is a complication of it. Poor socioeconomic status, people who are poor and belongs to low socioeconomic conditions are prone to get rheumatic heart disease because the sore throat and group A beta streptococcal infections are more common in poor economic status, poor nutritional status, poor hygienic conditions. Overcrowding, people who are living in a slum or dump area are more prone to get rheumatic heart disease because of the easy spreading of group A beta streptococcal infections. Age, similar to rheumatic fever, in rheumatic heart disease also it is commonly seen in the age group of 5 to 15 years. Climate and season, it occurs more in the rainy season and the cold climate because the people will be people will be occupied in the home itself when the rainy season, and their chance of getting group A streptococcal infection more frequently in these particular seasons. Next one is upper respiratory tract infection. Rheumatic fever is an outcome of upper respiratory tract infection with group A beta hemolytic streptococcus, and this can progress into rheumatic heart disease, and that is also another risk factor for rheumatic heart disease. Previous history of rheumatic fever, so usually carditis is progressing into rheumatic heart disease. So the client with the previous history of rheumatic fever are high risk of developing rheumatic heart disease. Next is genetic predisposition. Rheumatic heart disease shows familiar tendency. Some autoimmune responses are initiated in some uh, genetic or familiar tendency is shown in some autoimmune responses. Regarding the pathophysiology, it's very clear causative agent is group A beta streptococcal infection, and if it is left untreated, the sore throat or strep throat is untreated, it can lead to uh, rheumatic fever, and all layers of the heart and the mitral valve become inflamed. So valves are getting inflamed and the vegetation forms are formed, and as a result of that valvular regurgitations and stenosis is happening, and it leads to heart failure. So uh, this is a which changes which is happening in the rheumatic heart disease. So these are the some example which can be noted in bacterial endocarditis. Like in endocarditis, we can see some vegetation changes which is happening in the mitral valves. So this is the problems with stenosis and regurgitation. Like valve does not open all the way, it's not enough blood passes through. That is a stenosis. Narrowing of the valves can happen because of the vegetation formations, and regurgitation, that is the valve is not able to close properly. Valve does not close all the way, so blood leaks backwards. So this is the problem in regurgitation. So stenosis is the narrowing one, and regurgitation is the backward flow of blood as the cups are not closing properly. Regarding the pathogenesis, already we know it is a cross reactions are occurring, and as a result of that, vegetations in the heart valves occurs, and some Ascoff bodies is formed in the myocardium, and some pericarditis is happening. So these all cross reactions are leading to the valvular damage. Next is the clinical manifestations. Depends on severity and involved valves, the clinical manifestations can vary. In mitral regurgitation, easy fatigability and dyspnea can be noted. Signs and symptoms of congestive cardiac failures can be seen. Abnormal heart sounds can be heard, and heart enlargement can be seen. In mitral stenosis, tiredness and progressive dyspnea can happen, palpitations can happen, hemoptysis can be occurred, and cyanosis and heart enlargement can be seen in mitral stenosis. In aortic regurgitation, again palpitation and fatigue, widened pulse pressure, prominent carotid pulsations, and heart enlargement. So these are the, depending upon the severity and involved valves, the clinical manifestations presented in mitral regurgitation, mitral stenosis, and aortic regurgitation. Next is the diagnostic investigations. The physical examination and history collection can be done, so it gives a clear idea regarding the incidence of rheumatic fever or a strep throat for that particular patient. So if there is a sore throat which progressed into rheumatic fever, definitely the child should monitor for carditis and other involvement of the heart which can progress into rheumatic heart disease. So, diagnosis of rheumatic fever can be done with the help of Jones criteria and other diagnostic investigation. X-ray can be taken which shows the cardiomegaly. ECG can be taken, echo, Doppler echo can be taken so that a clear idea about stenosis or regurgitation can be noted with the echo. And cardiac catheterization is also, as a part of intervention also, we can do the cardiac catheterization, and also it gives a clear picture about the pressure variations and also regarding the flow of blood, whether it is obstructed or abnormal flow is noted. These are the diagnostic investigations which can be done for rheumatic heart disease. Next is regarding the supportive management. The first one is restriction of activity. Definitely, when the child's heart is involved, carditis is present, the child should be provided adequate bed rest, and monitoring of signs and symptoms should be followed. Next is the treatment of CCF. one of the main complication as a result of rheumatic heart disease or rheumatic fever or any congenital heart disease is the congestive cardiac failure. So development of congestive cardiac failure should be monitored and it should be managed properly. Next is the prophylaxis of rheumatic recurrence that's already discussed with the rheumatic fever, how to prevent the recurrence. So it is with the penicillin G. Benzathine penicillin G can be administered every 3 weeks for nearly 10 to 15 years. The child has to receive the particular treatment. Next is the prophylaxis of infective endocarditis, again with the antibiotics. And if the child is allergic to penicillin, we have to administer the erythromycin. Next is a surgical management. In severe mitral regurgitation, the management is with the prosthetic valve replacement. In severe mitral stenosis, it can be done with mitral valvotomy, balloon valvuloplasty, valvotomy or prosthetic valve replacement. And in severe aortic regurgitation, it is with aortic valve replacement with homograft or prosthetic valve. So these are the surgical management. Okay, and the nursing diagnosis, it can be the decreased cardiac output, then fatigue can be another problem, and activity intolerance can be another problem. Nutritional imbalances can be the, and also the child should be monitored for the prognosis and also the progress of the disease properly with proper echo ECG. Changes should be monitored regularly. So this is about the rheumatic heart disease. Hope you are clear. Thank you very much for kind listening. Thank you. Then nursing diagnosis already discussed, that is decreased cardiac output related to inflammatory changes in the heart, impaired tissue perfusion related to decreased cardiac function, fatigue or activity intolerance related to difference between body demands and metabolic supply. Anxiety of parents can be definitely present because the child slowly progressed into a very chronic condition, that is from a strep throat, it is progressing to rheumatic fever, and finally it's end up with rheumatic heart disease. So it can leads to anxiety of parents. And next one is the impaired family coping can be another problem because the family has to adjust with the changes very fastly and the child's progress should be monitored. So these are the nursing diagnosis. So thank you so much.